Okay. Welcome. Good to have you with me today to discuss this very important topic called mental health in adolescence in a global pandemic. And I think we could also say on re-entry from a global pandemic. Um, so today, this is what I'm hoping we'll be able to do in this talk. Um, First, that we can distinguish between what's anxiety, what are worries, what's depression, what's an adjustment reaction, and what is typical adolescent development. I also hope that you'll learn how to use the ASQ suicide screener and also what to do if you get a positive or negative screen. And I also want to outline where you can go to get more help and where families and young people can go to get more help. So I want to be very clear that this talk today is really a call to action because there are a lot of kids in need, as you all well know, from what you're seeing in your offices and in your care sites. And I think a few studies really highlight what is going on in terms of mental health for children and youth as a consequence of this global pandemic. This was a study published in the MMWR recently, looking at the last year of mental health related visits to emergency rooms. And you can see for young children, school age children between 5 and 11, there was a 24% increase in mental health related ER visits. And for teenagers, it was a 31% increase. And you can see that this trend has really continued over time and been quite significant. In looking at private healthcare claim records, we also see a significant increase in behavioral health claims. So this was a work published by Fair Health where they analyzed over 32 billion private healthcare claim records. And the green is really showing the 2020 data as compared to the blue purple color, which was the 2019. So you can see that really consistently starting in March, we've seen at least a 20% increase in these claims, letting us know that there's a lot, and this was with teenagers, letting us know there's a lot of need out there among the young people we serve. I think it's also important to recognize that we have a significant shortage when it comes to psychiatric care and treatment for children and adolescents. So the orangish brown color really shows severe shortage, which as you can see is the majority of the country. But even the gray areas depict a high shortage area. And so really almost the entire country, unless you're in Rhode Island or Hawaii, is under a significant shortage of child and adolescent psychiatrists. So I think kind of looking to ourselves to try to fill the gaps where we can, I kind of think about these things. One, there's a national shortage. So pediatric care providers are going to exert effort to fill the gap. We're in a global pandemic and coming out of a global pandemic, and many kids, as you well know, are not okay. A lot of kids are still closed this summer, and a lot of kids receive mental health services in school. And even those schools that returned at the end of the school year, it wasn't for long enough for kids to reestablish that kind of care and treatment. The other thing to recognize is a lot of adults are struggling too. And so the buffering support that caregivers can give to children and youth in their households, those caregivers are really stretched, whether it's financially, emotionally, or even in their childcare responsibilities. And so I think this kind of creates a real difference for us in how we approach care and treatment of children. So this study, I think, is very hopeful, and it's one of my new favorite reads. So this was an intervention that was designed to train 17 to 23-year-old lay callers with just a very brief training to reach out to older adults who were receiving services through a Meals on Wheels program. And what they really focused on was empathy-oriented phone calls to reach out to people in order to improve loneliness, depression, anxiety, and general mental health. And what I think is quite remarkable is that with empathic listening, the older folks really experience less loneliness, depression, and anxiety, and that these symptoms were rapidly reduced. And so, my point being that our empathic listening can make a difference. And I think this study is a great depiction of that. And I also find this study incredibly hopeful for young people, that young people's empathic listening in particular can make a difference for those they come in contact with. So, all right, so I've stated the need and why it's important that we all engage. And I'm going to go through a few cases that we've experienced that I think will probably be common experiences in your offices or care settings. So the first comes from a caller who says, the pandemic has been so hard for my teenager. They're lying in bed all day doing Zoom school. None of the activities that they enjoy are available right now. And I'm just not seeing as much smiling or joyful expression of emotions. And so the caller is worried. So I think the question from this scenario is really, how do we distinguish between normal adolescent ups and downs, depression, an adjustment reaction to a global pandemic? So I want to offer a few strategies. First, I think it's just good to look at the criteria. So this is DSM-5 criteria for major depressive disorder. And it's at least 2 weeks of low mood. I highlight irritability because sometimes for adolescents, the most common symptom is irritability as opposed to saying I'm sad or depressed. And then we need at least 4 of these other symptoms lasting at least 2 weeks. So the decreased interest, the decreased energy, the appetite changes, the concentration struggles, the difficulty functioning at home or school or with friends or a friend group, and that we can't immediately attribute it to something else. So I think many practices have engaged in screening for depression, and this is a practice that's been endorsed by both the U.S. Preventative Health Task Force as well as the American Academy of Pediatrics, both of which recommend at least yearly screening for depression in adolescents, because frankly, depression is really common in teenage years. So estimates are between 10 to 20% of teenagers will have at least one episode of depression over the lifetime. And also, this is a really treatable disorder. And so we want to identify things quickly that we can treat and help young people feel better. So we also really highly recommend using a standardized screening tool. So the PHQ-9A is in particular for adolescents, and the annual screening again is recommended starting at age 12. So this is that PHQ-9A questionnaire. And so you can see, 9 questions and then a 10th question really trying to get at that life functioning. I think really important to highlight to folks is really about how you've been feeling over the last 2 weeks. And then the scoring. So you really tabulate the columns, and a score of 11 or greater is considered a positive screen. So this is, again, not a diagnosis, but it maps out to those DSM-5 diagnosis criteria. So very helpful in then figuring out next steps. I think often also very helpful to have a conversation with the positive question answers to get a better feeling for what is going on. So a patient, for instance, might check that they feel tired or have little energy, but it might be because, they just started a new job and have a different schedule. And so that would explain why they were answering positively over the last 2 weeks. I think it is good to also know these screeners can be done over the phone or with a telehealth visit. So I think differentiating adjustment disorder from depression is especially important for adolescents. I kind of have this picture of middle school because to me, middle school represents that time of constant adjustment for a lot of teenagers where their bodies and their friend groups are changing a lot. And adjustment disorder is really where you can have these symptoms within 3 months of a stressor, but typically they last for 6 months. But a person can experience significant distress, and we can still call this an adjustment disorder. So, this can be when an acute event happens in a household, like a parental separation or divorce, where the young person may really experience significant emotional upheaval that goes on for several months as they adjust to the new situation in their lives. I think other diagnostic considerations, things that can look like a depressed mood with many of those major depressive disorder symptoms, are things like anxiety disorders, eating disorders, learning disorders, substance use. And then we don't want to, of course, forget about those underlying medical conditions, hypothyroidism, some of the rheumatologic disorders. Oops, not sure what happened there. So I think just good to make sure that we really include our whole differential diagnosis in trying to figure out what's going on for young people. So once you have done your screeners, had the follow-up conversation, and you really feel like the patient meets the diagnostic criteria for depression, then the recommended treatments include both cognitive behavioral therapy and medication. Studies show that the two together help people improve quicker, but both are effective care and treatment for depression. Really, cognitive behavioral therapy is that acknowledges that how we think affects how we feel and also how we behave. And so it's really helping teenagers gain insight into their thinking so that they can change how they behave and then change how they feel. It is also important to acknowledge that adolescents are within families, and sometimes there's a lot of conflict there, where family therapy is a very important care and treatment modality. So just sometimes it's both cognitive behavioral therapy with family therapy that's really needed to help adolescents live their best lives. This is a table that you can also find in the AAP depression guidelines, which are short and sweet, known as the GLAD PC. And so I give you the reference here. These are studied selective serotonin reuptake inhibitor medications, which are typically the first and second line treatment for adolescent depression. You can also see the doses and max doses and some particulars about these medications. Typically, we start low and increase doses in order to really prevent these common side effects. Most particular, those GI side effects that are the most common, starting with a low dose and then increasing to an effective treatment dose in a week or two is a common practice. I think it is good just to let people know about the vivid dreams and sometimes changes in sleep. And then, of course, folks will see that FDA black box warning about increased risk for suicidal thoughts. So good to give warning to people about that black box warning. and encourage them to call you if their child experiences those symptoms. So again, just reinforcing, starting low to avoid the side effects, really reminding people that it can take 4 to 6 weeks to see the dose effect fully effective. It's very hard when a person is experiencing symptoms of depression to be patient because it feels awful. I always tell people that I hope the medication works right away, but it's not unusual for it to take 4 to 6 weeks to see the full effect. Um, Really important to see people back in follow up in 4 to 6 weeks to assess how things are going. And it's also a time where you can figure out if you need to increase the dose or if if the patient is or is not responding. So this is a typical treatment plan decision tree. Um, you initiate the plan, and then 2 weeks later, following up is often helpful with a phone call. Some people do this a week out. And really, the purpose of this contact is to see, were you able to get the medication? Did you reach out to the therapist, and were you able to find one that could make an appointment? When is that appointment going to be? Are there any problems with starting the medication? And have you figured out a good time that works for you to take the medication daily? So that's really what that 2-week phone call is about. And then you'll see that 4-week phone call is really about that 4-week either phone call or in-person visit or Zoom visit is really a chance to figure out if there's any response to treatment. And then typically it's recommended 3-month visits thereafter if things are going well to make sure people stay in remission. All right. So there's obviously a lot more to depression care and treatment, but and you're welcome to reach out to us in adolescent medicine if you have questions or concerns. And we'll get to the resources at the end of this talk to just further emphasize what's available to you. So here's our next scenario. So for the last 6 months, this child has had terrible stomach aches. You've seen them several times. They're exhausted and sleeping poorly. They're very worried about going back to school. They used to meet with a school counselor for support last year, but that isn't happening right now. And so how do we distinguish, is this typical stress coming out of a global pandemic, or is this an actual anxiety disorder? So symptoms of anxiety, I kind of highlight that there are a lot of physical symptoms that will come into our offices that are very commonly experienced in the pediatric population. Stomach aches, headaches, feeling like your heart's racing are very common, as well as like trouble breathing or feeling short of breath or you can't catch your breath. And then, of course, there are, panic attacks and constant worrying, avoiding things that you're worried about. So I think just important. And again, I just kind of put a box to the side about the irritability because this is just such an important symptom that adolescents experience. So for generalized anxiety disorder, this is the DSM-5 criteria. So the worry for at least 6 months and that the worry is difficult to control. In children, it's really one more of these symptoms. So whereas for adults, it's 3 of them. But I often find children experience a lot of these symptoms too. So that irritability, the tired, the not being able to concentrate, kind of feeling that tension in your muscles and the difficulty sleeping. It, of course, generalized anxiety also affects functioning, whether that's at home or school or with friends, and that it isn't related to another medical problem or another mental health concern. So this is an anxiety screening tool called the GAD-7. I generally have found this one easy to score and easy to use and very similar to the PHQ-9A. It's an entry point into a conversation with a patient. I didn't mention this in the previous screener conversation, but really important for adolescents to fill out these screeners themselves, and ideally not with their caregiver looking over their shoulder. Because sometimes, adolescents will want to protect their caregivers in the home and kind of not acknowledge how they're feeling without some private space to do that. So the treatment is very similar to what we described in the depression scenario. So again, cognitive behavioral therapy and using the same selective serotonin reuptake inhibitors, and also that same treatment paradigm of starting the treatment, phone call in a couple of weeks, visit to the office in 4 to 6 weeks to check in. All right. So the next scenario is really a caller, and unfortunately, this is happening a lot more frequently right now. We're finding in our practice and in our emergency room where a caregiver will call and say that their child is experiencing suicidal ideation and they're not sure their life is worth living anymore. They let you know that one of the activities they really enjoyed, volunteering at the Humane Society, is not available to them anymore, and that the child is in the room crying and quite distressed over not being able to do the things they love and not being in school in the same way, and changes in their friend group. So the question for us is, how do we screen for that suicide risk? So I think for those of you practicing in Missouri, it's important to acknowledge that in Missouri, we have higher rates of suicide than the national average. And in the Missouri data from youth in the Youth Risk Behavior Survey, we had high results of young people feeling sad or hopeless, and a very high percentage of high school students considering suicide. And I think it's important to keep in mind this was before the global pandemic. So this is from data from 2019. And you can see that many created a plan, over 13.5%, and over 8% had actually attempted. So the CDC has spelled out these risk factors, and you can see that a lot of these risk factors are consistent with what people experience in a global pandemic. So feelings of hopelessness, the isolation that so many experienced, the barriers right now to accessing mental health care and treatment, loss, whether that's loss of a relative, a friend, a family member, loss of work or financial loss that families have experienced. Physical illnesses, many people, faced COVID-19 and they're continuing to recover over the long haul. And then in Missouri, we have some of the most lenient gun laws in the country, so there's often greater access to lethal means in households. So this is, in thinking about suicide, one of the models that people often think about is this social ecologic model. And really, it talks about the individual being in the context of relationships, being in the context of community, and being in the context of society. And that all of these can impact suicide rates in the individual. So you can see for the individual, of course, things like history of depression or mental illness, but then also if they're more isolated in their relationships, or there's less community connection or less access to helping providers, and then at a societal level, greater stigma or more access to lethal means, that these things kind of are working both on the prevention side as well as on the risk for suicide side in concert together. So let's think about what is possible in order to make a difference if we want to think about this social ecological model. So I feel like we can have impact at the community level by making ourselves accessible to helping folks find care and treatment. I know this is more difficult right now because of the global pandemic and the increased need. There are often longer waits for mental health care and services, but I think welcoming people into our offices to talk about these things and making sure folks are less isolated as they're struggling to find care and treatment is really important. I think also this is where our treatment of depression and anxiety um, can be really important, as well as the sharing of resources. There are other group interventions, parenting groups, and a teen outreach group. And then there are just fun group activities that young people can do. Many pediatric providers have been very engaged in the advocacy for full return to school. And I think we're going to need advocacy when the school year starts up again in the fall, because I think there's going to be significant reentry issues for young people and frankly also for school personnel, teachers, staff. And then I think we can continue to advocate for safe firearm storage. So looking at what we can do in our pediatric offices and care settings, I think it's important to recognize that screening for suicide really helps increase detection, and that screening in offices is really acceptable to caregivers and to adolescents in a primary care setting, and that we can actually do this in our typical patient care workflows. And I'm going to try to show you that today. So I know this is a complicated chart, but I know many of you, are doing this. And so we've already talked about administering the screeners. And so many of you are already using the PHQ-9 and the GAD-7. And then I think paying attention in that PHQ-9 to that question number 9. So how often in the past 2 weeks have you thought that you would be better off dead? So that's really kind of an entree question into the suicidal ideation rubric. Oops, going backwards. So this is just highlighting where that question number 9 is on the screener and highlighting for all of us to really make sure we pay attention to that question, especially these days. So if that question 9 is answered positive, then the next step is another brief screening tool called the ASQ, or Ask Suicide Screening Questions. And it's really this 5-question screener to follow up. And it also, at the bottom of the sheet, even has some resources there for you, both a crisis text line and a suicide prevention lifeline, but I'm also going to give you some local resources at the end of this talk. So, if a patient answers no to all of those questions, then you're good to proceed. And if a patient answers yes, and I'm going to go back one again just to show you. So it again reinforces that better off dead thinking. It again asks how often are you having, are you having those thoughts, and have those thoughts been recent? Have you ever tried to kill yourself? And then that really important question of, are you thinking about doing this right now? Because this obviously determines whether the patient really needs an intake immediately, or whether these are more passive suicidal thoughts and the patient can articulate to you why they would never want to do it, as well as if they were having those thoughts, who they would go to for help and support. So this is one of those situations where you can see kind of in another scenario where something happens where maybe a kid isn't feeling so great and then a relationship ends, or they articulate to a parent that they want to die, or something happens on social media, which can be quite upsetting to young people. And then really caregivers are calling you with these questions about whether a child is safe or not. And that's where these screening tools can be very helpful and also give us some structure to rely on that's been studied in the field about using these screeners to determine what the next steps are for the child. And so when we go back to that decision tree, we've done the screening, we've looked at question 9, we then embrace using the ASQ, which you can also do over the phone, and that's been used in the field over the phone. And then we really try to figure out from this decision tree, so are we in this high risk place where the patient has a plan, they say they feel like they want to kill themselves today, they don't have a lot of support, and you don't feel like the patient is safe. So that's really the time when you're referring to intake. If the patient says, yes, I've had thoughts that, my life isn't worth living, but I don't have a plan. I really like those thoughts were several days ago. I'm not having those thoughts now. I know I would go to my caregiver if I was having those thoughts. Then we can really feel more assured and provide resources, close follow up, and really try to ensure that the patient still gets important care and treatment, and that they get the kind of treatment they need to help themselves feel better, and that we follow up in fairly short order to make sure that they're still safe, recognizing that breakups happen, stressful situations happen, and that these things can change. So these are some of the triggers that I try to pay attention to figure out whether somebody needs to go to intake. So if they have a plan, that really triggers me to go to intake. If they can't commit to safety, if they can't, whether that's in the next 24 hours or until the next visit, all of these kind of groupings really would make me send somebody to intake. If really they say, this plan is imminent that they're going to put in place, and if they talk about in their plan using a firearm. So, and of course, if they also talk about hurting somebody else, that's an immediate, not just themselves, but hurting somebody else. That for me is an immediate trigger for an intake evaluation at a psychiatric place or an emergency room. So I'm going to break it down a little further for you, and this is the ASQ here. These are some helpful resources if you find yourself with questions. So one is the MoCPAP, which is a psychiatry on-call number that's available during business hours that you can call and get quick access to a psychiatrist who's there to answer questions and concerns from providers. The BHR resource is a 24/7 call line that can be given to patients and that you can also use to help figure out where to send your patient as well as resources. I also have placed on this decision tree the intake facilities here in the St. Louis area, but just know that that BHR 800 number is available throughout Missouri, and so is MoCPAP. So that's why I kind of highlight those ones in particular. What I think is the hard places is this gray area in the middle, and I think this is where the struggle is for all of us. So when someone says, I'm thinking of killing myself and I have a plan, I think all of us know to refer that person to the intake at these places, or if you're somewhere else in Missouri, to an emergency room. I think when people answer no, we know to make sure we're getting resources, support, really team-proofing the home and giving these emergency contacts. I think it's hard when we're in the middle, when they say, yeah, I'm having thoughts that my life isn't worth living, and I'm not having those thoughts today. I do have some caregivers in my life that I could go to, but we still just feel a bit of unease. And that's where I think these resources of MoCPAP and BHR can be especially helpful, as well as close follow-up. So a little more about MoCPAP, available 10 to 6, Monday through Friday. It's really designed to give you timely telephone support in making these difficult decisions, as well as other clinical decisions you may have about your patients in the psychiatric realm, and just some feedback from providers who've used the call line, which has been very positive. I think it's also really important to remember, even for those young people who say not at all, like I'm not having those symptoms, there's still a lot of care and support that we can offer. And just because someone isn't having suicidal thoughts doesn't mean they don't need care for their depression and anxiety. And or that, it's good for all teenagers to have a safer home and resources and to practice self-care. And so I think I never want to forget. I know we spend a lot of time focusing on those kids who we worry the most about. And I think it's right that we worry about them because suicide is the second most common cause of death in adolescence. But I don't want to forget about those kids who are over here, who are still experiencing symptoms or who have lived through a global pandemic and are coming out of it. And I think, helping people kind of re-enter and live their best lives is really important work to be done. So another question that commonly comes up is, what if people don't want to do the care and treatment you recommend? And so these are some tips that may be helpful for those who are more hesitant or even, who don't want to go along with your recommendations. So one, sometimes people don't get all the correct information. So, sometimes depression has different meaning to them when we say that word. And so I think just making sure that everybody knows that depression's treatable. We're not saying this is a lifetime illness. For many people, it's one episode, they get better, and that's the end of it for them. So I think important to just really acknowledge those things for caregivers and for young people themselves. I think it's good if someone's refusing treatment to just express your worry, say I'm worried about how they're feeling and how they're doing. And also, kind of the impact in their lives and with their friends. I think it's good to kind of stress why it is that you're worried. And then I know right now kind of access to professional therapists can be very frustrating right now. There can be weeks worth of waiting. And so I think looking for other trustworthy adults that can support people. And I think about, faith leaders or coaches, school counselors. Many of these folks are, school counselors are professional therapists, but if there's access to them, that can be very helpful. And then I think the things that help us all feel better. So physical activity, getting outside, getting up and out of bed, trying to have some kind of schedule, doing mindfulness. These are all things that help us all feel better, even if in the just life up and down things that we commonly experience. And then I think good to make sure patients have access to that 24/7 crisis line of BHR. There are also, if you're struggling to find therapists right now, I hear you. And there are also resources available through 4514. That's their phone number. They staff this phone between 8 and 4 during the week. They'll take a patient's insurance and where they are and help find therapy resources in their area, in the patient's area. So I think another helpful resource for you. These are some of the mindfulness apps and mindfulness websites. A lot of patients I know will Google YouTube mindfulness breathing, and you'll come up with a lot of choices. So just, I think another thing that we can really encourage, even if it just provides a few minutes of relief for folks. So I think you all know from the very important work that you do that kids and families are hurting. I also want you to know that your empathic listening makes a difference. Even if we can't solve it all in that visit, the listening that you do is really valuable and important. I hope because we're coming out of this global pandemic and we know kids are hurting, that you'll think about adding the ASQ screener and paying special attention to that question number 9. in the PHQ-9. I hope that you'll offer resources to your patients, and that we've offered a couple resources to you. In particular, I find BHR, because it's 24/7, and the 4514 especially helpful resources. In the next slide, there's a bunch of articles and videos for you to watch, as well as a lot more information about the ASQ and the GLAD PC depression guidelines. So I hope that this will be helpful to you and to the kids and families that you serve. You, of course, are also welcome to reach out to us in adolescent medicine. We know these are challenging times, and for anyone seeing pediatric patients, and that the global pandemic has been really hard and stressful for kids and families. Thank you very much for your time today.